Good evening and welcome to my YouTube channel, Pain Free Partha, on my website where slides are freely downloadable and editable, www.painfreepartha.com. This topic was actually taken by me in an ISC Pondicherry a few years ago, which I am making it as a video before exams. How to face drug viva station in the examination. When you sit down, you should slowly smile with less tension. Project and inform your number first, because that is very important. After whatever it is, the number is confusing, means it's I am 00020 21, something like that. So some examiners will tell, start, you did your long case very well, very good, proceed. And some examiners will tell the same person, you did your short cases not all that well. This fellow is the same person. But some examiners usually tell the positive things, and rare examiners will tell your short case was very bad. Don't do anything. Need not worry. I will try my best and again tell your number. Sit in the viva for drugs. It will be like this. You can see here, no? Two options. The drug is chosen by the examiner. He picks up the drug and gives to you. Sometimes the examiner asks you, come on, take one drug. The drug is chosen by the candidate. Option one means the examiner chooses, means, okay, you have done relatively well in your examination, short cases, long cases. He wants to tell you and give you push-up marks. If the performance is not that good and you need improvement, means usually the examiner helps you and taking the drug whatever you want and tell. In both the cases, the examiner is helping you. Okay. Drug viva station. It's a journey to MD. It is not police station going on asking questions. Now option one, a routine examiner. Thiopentone, succinylcholine, vecuronium, all these things he will be having, and he will give vecuronium, succinylcholine, thiopentone, fentanyl, midazolam, all these drugs. A non-routine examiner may give you mannitol, soda bicarb, all these things. Some freak examiners will put in their pocket and take you the D-tubocurare, only 1 ampule so far in the world. And he has used in his own postgraduate days of 1980s, and he will come with that. Now, what did they expect? An examiner expect what? What is the trick? And some points needed, always methodical. Now, for example, if you start with thiopentone, all examiners expect the candidates to know A to Z of thiopentone. Nothing should be wrong in thiopentone or propofol, whatever it is. Commonly, daily used tricks. Now, you start with a barbiturate intravenous injection agent. You start like this. Now, you are also happy. They are also happy. Something is told. Come in vials. They come in what powder, yellowish powder. That is why it is called thio. Something like that. Or 6% carbonate is there. What is the dose? 2 to 4 milligrams per kg IV. What are the indications, contraindications, special features? For example, special features of thiopentone. What is that? It is useful in coma. It's something like that. Barbiturate coma to induce. It is an anti-epileptic. Something like that. It is good in ECT. Something like that. Now, ketamine can enjoy like that as soon as the drug is given. So, what is this? It's what is the derivative? How the vial comes? What are the dose? For example, thiopentone only will be given IV, but ketamine you can say IV, IM, subcutaneous, intranasal, intrathecal, epidural, so many things. Ketamine patches are available. So, what are the special features? This is what is important. Analgesia. It is not there with thiopentone. Shocked patient, bronchodilatation, mechanism, nystagmus. We can give increased FiO2 because of analgesia. So these things, for example, you need 40% FiO2 in a patient. Just give ketamine and increase your FiO2. The patient will not become aware. So these subtle points, which are very specific about ketamine, should be told to get more marks. Now we go routine examiner, option 1B, non-routine examiner, he comes out with mannitol. Mannitol, what is it? How available, dose, route, indications, and precautions. It's a sugar, that is what you should tell. If you tell it is a sugar, then it is fine. 20% solution, 1 gram per kg IV. So there are a lot of indications and contraindications. I am not going to detail each drug. That is a separate topic. I have my video of barbiturates. I have my video of ketamine. I have my video of propofol, all these things. So I'm not going into the details of this. Once see, if you know Quebec or invalid, fine. If you don't know, you just tell I have not used it, I have not read this, then they'll go to the next question at least. In this 10 minutes, they can get some points from you at least. Give marks. It's natural. Cure, arrow-poison. Bernard was the one first find out. 3 to 5 milligrams IV dose. Curare mimetic. That is why it is called curare. Curare is the first neuromuscular non-depolarizer. So, whenever you say another drug, it has got curare mimetic action. The patient becomes paralyzed again, we call it as recurarization. Curare. The candidate select, tell me vecuronium, and no mistake is available. Always tell the salt, vecuronium bromide, antraquinium bacillate. Comes like that. You tell that, then they know that you have read that and you are telling. Non-depolarizer, steroid, lyophilized powder, intermediate duration. What is the dose for maintenance, intubation, all these things? What important is this? You should tell you need add fentanyl or vecuronium bradycardia. Liver danger is there, but renal failure is like you. Okay, this is what we should tell. It's a steroid. So we can extubate or reverse with sugammadex. Certain points are specific for vecuronium, liver, something like that. This has to be told. Mild ego, if it picks up sodium bicarbonate, then you should tell 7.5% or 8.5%. What is the milliequivalent per ml? You should treat cardiac arrest, acidosis, other acidosis with caution, fluid hyper overload, hypocalcemia are the dangers. We should not extravasate. That is very important because it is really irritable. It goes into it gets a big swelling is there. We can have nebulized sodium bicarbonate. Sometimes people will stroke like coli. Nebulized bicarbonate, pulmonary injuries. Sometimes I will add in epidural. I will add in nerve blocks, especially in inflamed tissues. Those things put you in distinction. Option 2C, you may select ephedrine. Ephedrine, a stereoisomer, better known as sympathomimetic, indirectly acting. Usually examine us. What is the difference between ephedrine and phenylephrine? Indirect acting, direct acting, tachycardia, bradycardia. So these things has to be very clear. So what is the dose? 6 milligram IV shots. How come phenylephrine comes at 300 milligram or sometimes 15 ml? Something like that we should tell. What is the dose and how is the route? Ringer lactate solutions, ions of lactate. Somebody will say, Ringer's, what is that? Ringer's lactate is what is it? Plasmalite is what? Hartmann solution is what? All these things they may ask. Plasmalite ko Hartmann's ko, what's the difference? Ringer ko Ringer lactate ko, what's the difference? Something like that. Diazepam versus midazolam. Faster answer, less pain on injection, better amnesia. Changes weight on combination diazepam. So midazolam has a pH dependent so-called ring closure phenomenon. It becomes more aqueous so that pain in injection is not there. As soon as it is, it becomes more fat soluble and then goes and hits the brain. This is the midazolam versus diazepam. You pick up dextrose, always be clear in percentage. What is dextrose? Somebody will ask. Dextrose is D-glucose. What is its pH? Somebody is asked. Because pH may be around 4 to 5 or something like that. And why, somebody may ask. Why pH is? So go and read. So 10 times all these things should be read because it is very common to give all these drugs. So whenever you are taking the drug, if something is this is there, no mistake is allowed. So practice again these so many drugs. Propofol means it's a non-barbiturate IV induction, milky white, 1% solution. Why these additives are there? Soybean, what is the role? Lecithin, what is the role? 1 to 2 milligram per kg or 2 to 3 milligram per kg. Sedation, ICU. What is the more important thing? It is useful in TIVA. Why? Context sensitive half-life. It does better nausea vomiting. Spasm is less. Supraglottic refluxes are decreased. So we can put an LMA with this thing alone. All these things are special points with propofol. For a candidate, sometimes we told to pick up something, he was doing like this, and suddenly picked up this, which was kept for the examiner. And then after eating that, he picked up actually the drug. Facing drug from the candidate point of view, from the examiners, especially the internal examiners, it's a lengthy special session we cannot do. As soon as the answer comes, the internal examiner will turn that side, this side, do like this. He cannot tolerate certain things. Don't make your internal examiner like this. Usually examiners are come there to do assessment of what you know and assessment of how you know. Rarely skip. Examiner gets a crucial mobile call and he skips whatever you have said important and very well the answers and he skips that. This is very rare, but usually examiners are kept the mobile somewhere else only. So practice at least 12 to 15 drugs again. Stay cool, tell your number. As soon as the examiner takes, be confident and blast. Focus on the drug's importance. Take the examiner to the field. For example, if you know very well Hoffman degradation, you again tell Atracurium Hoffman degradation so that you can know very well. Examiners are completely different. Don't think this examiners will be, they will be like this. I am different, he is different, she is different, or something like that. So always examiners are different. You cannot satisfy some examiners, but read basics very well. Read the 15 commonly used drugs, thorough A, B, Z, answer. You are in for a good mark.